Mrs. Brown, a 78-year-old woman, was admitted to the hospital with a one-day history of abdominal pain, nausea, and vomiting. She had a known paraumbilical hernia that had been present for many years without symptoms. On the day prior to admission, she noted that the hernia had suddenly become larger and more painful. On examination, vital signs were normal, but she was in distress due to pain. Her abdomen was distended with a visible, tense paraumbilical hernia. The overlying skin was erythematous. Laboratory studies showed a leukocytosis of 15,000/ml. Abdominal X-ray showed dilated small bowel loops with air fluid levels concerning for small bowel obstruction. A CT scan revealed an incarcerated paraumbilical hernia containing fluid-filled small bowel without evidence of ischemia. Nasogastric tube decompression and IV fluids were initiated. The patient was taken urgently to the operating room for open reduction of the incarcerated hernia contents. At surgery, the small bowel was reduced from the hernia sac and appeared viable. The hernia defect was closed primarily with sutures. She had an uneventful post-operative recovery and was advanced to a regular diet by post-op day 3. She was discharged home on post-op day 5. On follow-up, she was doing well, and the incision was healing without signs of infection. Commentary questions. What are the risk factors for developing a paraumbilical hernia? Risk factors include obesity, prior abdominal surgery, ascites, dialysis, smoking, collagen vascular disease, abdominal distension, heavy lifting, multiparity, and conditions that increase intra-abdominal pressure. How does an incarcerated hernia differ from a strangulated hernia? Incarceration refers to irreducible hernia contents that may still have intact blood supply. Strangulation refers to compromised blood flow to incarcerated contents, which can lead to ischemia. What is the appropriate emergency management for a patient with an incarcerated hernia? NPO status, nasogastric tube decompression, IV fluids, analgesia, and prompt surgical consultation for possible urgent operative repair. Delay can lead to bowel ischemia and necrosis. When is mesh repair appropriate for umbilical/paraumbilical hernias versus primary suture repair? Primary repair is used for urgent/emergent cases where mesh increases infection risk. For elective cases, mesh reinforcement helps decrease recurrence risk and is often preferred. What measures can help prevent complications and recurrence after hernia repair? Avoiding heavy lifting, managing ascites, losing weight, smoking cessation, controlling constipation, proper surgical technique, and use of mesh when appropriate. Follow-up is important to monitor for recurrence.